Bismillah. We are starting the third session. Our first speaker, Dr. Muhammad Ali Khalifa Bablik, Baghdad University, Faculty of Medicine, MD Syria, board 5 years, Damascus, fellowship, arthroplasty and arthroscopy from National University, South Korea, associate professor Al-Fahd or Al-Haft University, National University of Sudan, consultant orthopedic surgeon, Arab Hospital, Faculty of Medicine. His book more than 3,000 operations, including total knee and total hip. Welcome, Dr. Muhammad.
السلام عليكم ورحمة الله وبركاته. Ladies and gentlemen, our talk today is about trauma care in orthopedic injuries. Orthopedic trauma are involved in specialized treatment the same. Yeah. لا ما ضغط عليه. في مشكلة ما ضغط عليها. كانت سلايد بعدين تحول للي بعده.
طيب ممكن اعملها خلاص اوكي صح كلام اعملها خلاص بس مش لو كان عندك مباشره اقل يقول انت بتقول اقل.
انا بحرك السلايدز. اوكي تمام. Thank you. Good morning, ladies and gentlemen. Our talk today is going to be about trauma care in orthopedic injuries. Orthopedic trauma are more involved in orthopedic trauma care involves specialized treatment of injuries to the musculoskeletal system, bones, joints, muscles, and tendons from accidents and other events requiring prompt diagnosis, specialized surgical interventions, and extensive rehabilitation, restore function, and prevent long-term complications. This care being with immediate emergency assessment and stabilization progresses through surgery and continue with this physical therapy and recovery to ensure proper healing and return to daily activities, often involving dedicated team of medical professionals from different specialties. Types of injuries. Fractures and dislocation, broken bones, fractures and displaced joints, dislocations, and common orthopedic traumas that need immediate care. Open fractures, when a broken bone breathing the skin, spreading to high speed infections. Complications often from high energy events like car accidents, motorcycles, and other involve multiple fractures and severe soft tissue damage, involvement of nerves and blood vessels. Next. Older patients if they fall down, this will lead to fractures. This is most commonly intertrochanteric or subcapital or transcervical fractures. Next. Definitely after you deal with this is surgical intervention. DHS, dynamic hip screw, and immediate mobilization after treatment. First of all, when you receive a patient from the emergency, you should put in mind that young doctors should be carefully care about these patients. First of all, when you receive such a patient, you should have to put him in low molecular weight heparin because those are the high risk of developing deep venous thrombosis and other complications. Next. Gunshot. This is inlet and this is exit. So these wounds always consider contaminated until proved otherwise, because when any patient exposed to this is considered as a war injury. So war injuries are contaminated until proved otherwise. And the proper way to deal with, you should have to put on external fixators, which are many types of fixators. Next. This is external fixators, and you should have to align the bone and put KOS if needed in the fibula, and then shunt screws in the tibia. So you keep alignment and contact bones so as to heal. And before you are doing this, you should have to irrigate well and make a well wash for these wounds, because these wounds can contain a lot of things involving inside the wound, piece of clothes and other contaminated things. Next. Motorcycles, and this is the most somebody mentioned before few minutes. We didn't mention something about the motorcycles. The cycles here with a high speed equal lead to this crushed limbs. Doing our best to keep limb salvage for such injuries, this is a very essential. So this patient unfortunately presented to us with a cold limb from the site of accidents to the emergency unit. So doing our best to keep amputation below knee, because no any vessels here are working, or the muscles are crushed, bones are a lot of losses from the bone. So we do our best to do below knee, but unfortunately we find some other complications. Next, this is a tourniquet, mining those in peripherals when you are doing any tied tourniquet around the limb. This will going to be swelling. This patient is presented to us with road traffic accident from a cycle with a car in one of the traveling routes. So when presented, he has a concussion, head injury, and also this trauma, crushed limb. So this patient admitted to ICU first to do the necessities for head injury, and then after stabilizing and Glasgow Coma Scale is stable and the patient is fit for surgery, we do our best to do this. When we examine here, we see a dead muscles which have no response to any punch or any mechanism, so that we should have doing our best to do the amputation here, but this prevent us from doing this, so we have to go above, which is unfortunately ended with above knee amputation. And this is a catastrophic from motorcycles accidents to lose one limb and have another injuries, plus minus. Okay, next. This is a young patient, 20 years old, using a saw in a workshop, pushing his hand inside the saw, and then put a traumatic injury for the little finger, and then complete cut of the superficial and deep tendon of the flexor tendons, the ring finger, fortunately on his left limb. So our best is to stop bleeding and do prepare for surgery as elective case, because you cannot make a repair of the tendons in such emergency cases. You should have to do remove the fashioning the amputation here and close the wound in a nice manner, and then you should have to repair superficial and deep tendon. Next. This is the repair of the tendons. This is a deep and superficial bifurcation of the superficial tendons. Next. There is a video here, please. Just play a video. Next. Complete this video. This is after repair of the tendons. Superficial bifurcation.
This is a deep tendon and this is a superficial tendon, okay, and had been repaired.
Mining to keep this,
and this is had been sutured. It is up to here,
to catch up the tendon.
okay. Thank you.
To catch up the tendon, you should have to open up to here to reach the tendon. Then you should have to repair both superficial and deep tendons. So keeping the healing in moving manners. Keep movement of flexion and extension. The extensor group is doing well, so extending, and then a rubber will push as a flexor. Okay, keeping this in healing in a movement way to avoid adhesive complications. Next. So key aspect of the care: initial assessment and stabilization. Emergency care, rapid assessment to identify and priorities and life-threatening injuries through procedures called triage. And triage have a lot of possibilities and it needs an experience. My address and home message to those young doctors who are being at the emergency units. Professor Ali mentioned in his lectures about the massive casualties. Massive casualties always happens in earth crack and sometimes turnover of a big bus carrying more than 40 passengers. So when presented them to the casualty, you should have to make sure that you know what is your target and what is your goal to classify or triage. Fortunately, I have been work with Professor Ben Mark, the senior surgeon of ICRC, International Committee of Red Cross, for a while in South Sudan. He had a good experience in dealing with the triage. Their system is very nice, really, and this should be stopped to learn from them as NGOs. The classification of International Committee of Red Cross for triage, they are using colors to classify patients in the emergency units. They use green color for those who are nagging and are to do with. So don't you lose your time with the patient who are safe but are talking and urging a lot. So you should have to agree on this safe patient. So you focus on, next one is this yellow color. The yellow color may be, if you have the vital signs and prepare the samples of blood for blood grouping to prepare them for surgery, because the yellow color may change to orange color, and orange color could be changed to red, so that you should have to attend emergency operation. So you should have to prepare your blood and do your best in the use of all this in the emergency unit to help you in your job. Today I have found 133 patients come as a one gush of massive casualty. You can see all the ugly system in this casualty. So this needs a lot of experience. So using this labeling manner of triage is very helpful to clarify for those who are young doctors and teaching. So next, button, the previous one. Previous one, رجع السلايد. Okay. Okay, neurovascular check. You should have to examine if you have enough time after assessing if there is any neural damage or vascular damage for the patient, and you should have to consult your colleague in different departments to make use of their experience in this, carefully clearing and managing the open fractures and prevent infections. So a preventive dose of a prophylactic dose of antibiotics should be given for those who have a big trauma or wounds. Next. Surgical intervention, specialized surgery, orthopedic trauma, specialties from specialty perform surgery to realign bone and stabilizing fracture and repair damaged tissues. The goal is to restore stability and function and of injury musculoskeletal system, so that our goal is not to end with the surgery. So after surgery, you should have to rehabilitate the patient to make sure that he is going to be functioning again and take on his work and to follow him. Next. Recovery and rehabilitation. Post-surgical care, continue monitoring and care in hospitals, promote healing and prevent complications. So to avoid complication, you should have to start involving physiotherapy and occupational therapy. Occupational therapy, sometimes in such injuries, you might have to change the job or the work of the patient. Its injury is making him hindering. Next. The orthopedic trauma team, multidisciplinary approach, a team of orthopedic surgeons, nurses, therapists, and specialties working together. So this is a harmony between different specialties and collaborating all together to make a job of is to make the patient again functioning well and in a good health thing. Nurses and other staff receiving ongoing training on orthopedic specific care. Next. So factors influencing outcome. Early specialized care assessment essential to prevent complications and ensure proper healing. Patient centerless readiness involving patients in their care and communicating clearly, avoiding medical jargon. Systemic support. Overall trauma system involving pre-hospital care and rehabilitation resources significantly important in patient outcome. So our home message for doctors, they should have to clarify, first of all, everybody in the emergency should have to know this its job. And first of all, when you are coming any patient, you should have to take a blood sample, sent for laboratory to classify blood grouping and prepare if this patient is in need of emergency theater. So putting in mind that careful and irrigation of a big wounds with enough saline to make sure that clear surgeon. All the patients came with a traumatic like so and others, you should have to give for them anti-tetanus injection to avoid any complication that's come out of these injuries. Next. Final. Thank you.
شكرا دكتور. Lecture. Now to the second lecture.
شكرا.
The second is the Dr. Ahmed Fathallah from Saudi Arabia, the management of pelvic injuries, consultant general trauma and acute care surgeon in Jeddah, First Health Cluster King Abdulaziz Hospital, serving a trauma lead at the hospital, completed his fellowship in trauma and acute care surgery at King's Saudi University Medical City, Riyadh, held multiple leadership roles, including University Medical, including Deputy Program Director of General Surgery at King Abdulaziz Hospital, and has contributed to the development of trauma systems, policies, and pathway at the hospital and cluster levels. Management of pelvic injury. تفضل دكتور.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's a true pleasure and honor to be here today among distinguished colleagues and friends. And I'm grateful for the opportunity to share and learn together. أخوكم أحمد فلاتة. I'm Consultant General and Trauma and Acute Care Surgeon. I had my board training in Saudi Arabia and my fellowship training in King Saud University in Saudi Arabia. I'm interested in surgical education and mentorship. I have nothing to disclose. So our talk today is about the pelvic trauma and why it matters. It holds a high mortality from exsanguination in early phase and sepsis in late phase. The recent American Association for Surgery of Trauma, the AST, multicentric observational study of patients with pelvic fractures from 11 centers demonstrated a mortality of 32% in 178 patients presented in shock. Usually the source of bleeding is the venous plexus, which is the most common, followed by cancellous bone, which is a porous lightweight tissue found inside the bone, and then with the less common is the arterial bleeding. Our goal is to reduce the volume, improve tamponade, and balanced resuscitation. So when we have patient in the trauma bay, we always start with the ABCs. We need to minimize ED to bleeding control time, which improves survival. Lactate and base deficit are both sensitive markers for shock and resuscitation response. Pelvic X-ray and EFAST in unstable patient, which both detect injuries needing stabilization, angiography, or laparotomy. Stable patient should go for multiphasic contrast CT to rule out pelvic hemorrhage. Pelvic X-ray will confirm the fracture, but remember, any fracture pattern can bleed massively, not just an open poke or vertical shear. Always check the perineum and genitourinary system. And if you find an open poke fracture, always back right away. So this is the Young Burgess classification for pelvic fracture, anterior posterior compression and lateral compression and vertical. Will not take long in these slides. There is Wiss's pelvic injury classification, minor, moderate, severe, according to the Young Burgess classification, and hemodynamic stability and mechanics of the fracture, and the need for CT scan prior to initiate the treatment. So first things first, we know when there is an opening of size 5 cm in the pelvic ring, it's associated with increase in pelvic volume of 10 to 20%. Therefore, if you have any stable trauma patient with suspected pelvic fracture, put on a pelvic binder right away. It doesn't matter what's the pattern of the fracture. The binder just reduces the volume of the pelvis and buys you time to complete your resuscitation, and you go for definitive fixation. And with suspected pelvic fracture, always forget the classical log roll. It disrupts any clots and worsening the bleeding. Instead, just lift and slide the binder beneath the patient, and if you have to examine the back, you just tilt minimally to inspect. go with damage control resuscitation, which is the massive transfusion protocol with balanced transfusion, calcium, minimal crystalloid, and allow for permissive hypotension if there is no TBI, and always don't forget the tranexamic acid. So when we have the pelvic binder, we always place a trochanteric and tighten it firmly, and we don't place it at the iliac crest. And you have to always monitor for skin ulcers. It can appear in hours. This is the right way of applying the pelvic binder or sheet. This is a sheet, this is binder, another type binder. Again, when you have the fracture, the binder will align it together and reduce the pelvic volume. You can always tape the both legs together to help you in the alignment. So the decision pathway, when we have a pelvic bleed and we have a concurrent hemorrhage source, we have to go to operative intervention. If there is no IR, we go with pre-peritoneal backing plus minus external fixation. If we have IR available, we go with pre-peritoneal backing plus minus angioembolization, and last option is RIPOA, which is falling out of favor. So we have a consistent pattern here. Pre-peritoneal pelvic backing works. It's magical and effective, and it makes sense as most pelvic bleeds are venous. So tamponade plus effective resuscitation become the first line of management and true life-saving. Now, when we have a concurrent hemorrhage source, pelvic and interabdominal bleeding can coexist in 15 to 20% of unstable patient. Fast positive and shock, we have to address interabdominal hemorrhage because it's uncontrollable solid organs such as liver bleeding can be rapidly fatal. Pelvic hemorrhage, which is mostly venous, is tamponadable and can often be temporized with binder, so keep the binder. Time to control is key for survival, not perfection, but fastest effective sequence. Pre-peritoneal backing, the benefits of pre-peritoneal backing are the following: shortened time to bleeding control, decreased mortality, rapid cessation of hemorrhage through control of venous, arterial, and bony source of bleeding, the ability to perform additional life-saving operation interventions concurrently, and the ability to use the adjuncts such as RIPOA, angioembolization in a complementary matter. There are many studies conducted in regards for comparison of IR, angioembolization, and pre-peritoneal backing. The mean time of initiation of pre-peritoneal backing is 60 minutes versus 194 minutes for angioembolization. So the pre-peritoneal backing is faster, and it makes sense that it's increase the survival rate. And it's not just for venous bleeding. The tight pre-peritoneal bags compress the internal iliac branches, reduce pelvic volume, and slow arterial flow. This buys you time for resuscitation and makes the patient stable enough to go for angioembolization if needed. Usually, if you have a interabdominal bleeding and pelvic bleeding, you open the periton until the umbilicus, and then you leave the periton intact below that to perform your pre-peritoneal backing. However, if you have a open periton with pelvic bleeding, or you don't have interabdominal injury, you can go all with the fenestrian incision. It's 2 centimeter finger breadth proximal to the pubic tubercle. Usually the length is 10 centimeters. You open there, you open the fascia, and you'll find the urinary bladder extraperitoneally. You push the bladder and you back both sides against the bony structures, not only the side wall of the pelvis. So when we remove the bags after 24 to 48 hours, we restore the physiological derangement, and we correct the coagulopathy. And always don't forget gentle removal after soaking with saline, so you don't disrupt any formed clot previously. As any type of surgery, there are complications could arise. Pre-peritoneal backing complication. The most feared complication is pelvic space infection. The overall risk is low with the single pre-peritoneal backing. It means one-time backing, which is 4 to 6%, similar to angioembolization 3.7%. high risk with open fracture or bladder or bowel injury. Repacking is a major risk for infection, as it increased the risk of infection to 45 to 47 if the pelvic space had to be repacked. So that's why it's crucial to fix the coagulopathy, improve the derangements before removing the back. Now we talk about angioembolization, which is a complementary, not a competing options. It's always followed the pre-peritoneal backing if ongoing bleeding occurred. 13% of patients with pre-peritoneal backing ultimately require angioembolization, but 50% of patients who undergo angio alone ultimately require angioembolization. So angioembolization is usually delayed 10 hours after triple packing, allow triple P, and allow stabilization for other procedures, and always be safe and selective in embolizing an injured vessels. Now when we go for angioembolization, what we do is perform only with evidence of arterial abnormality or angiography, use selective direct angiography, and recognize subtle findings such as abrupt vessel cutoff, size discrepancy versus opposite side, and localized spasm. Use angioembolization as complementary to triple P and X-fix. We don't empirically embolize internal iliac arteries. Avoid proximal occlusion only as collateral already disrupted, and don't delay triple P or operative control in unstable patient. So in short, angioembolization is about precision over obliteration. Go distal, be selective, use coils. It will form stasis and thrombosis within 15 to 20 minutes, and just you need to slow the flow and let the physiology finish the job. Again, it's an intervention. It saves lives, but it's not without risk, especially if it's umbilical or proximal. Access complication occur, pelvic ischemia occur, gluteal necrosis, even sexual dysfunction have been described. That's why selective distal embolization is the guiding principle here. Next option is external fixation, which is a part of damage control surgery in unstable pelvic fracture. Supraacetabular pins are preferred as they are more biomechanically stable. Anterior fixation alone is insufficient in vertical shear or comminuted or spinopelvic dissociation. When combined with the triple P, it gives a better results. This is a picture of the X-fix. Of course, the hybrid room is the game changer. It allows simultaneous resuscitation with angiography and smooth transition between laparotomy, angioembolization, and X-fix if they're used. Now, when we are inside the peritoneal cavity, if a pelvic hematoma ruptured into the peritoneum and caused massive bleeding at laparotomy, we have two options. The first one is bilateral internal iliac artery ligation, which is a useful adjunct when laparotomy already done, and can be temporary with loops or clamps or permanent ligation. There are downsides of it, which prevents future angioembolization as the artery no longer cannulatable, and often ineffective if unilateral, as cross-filling via collaterals occur. Even bilateral ligation may fail due to collateral circulation coming from vertebral arteries. The other option is intraoperative surgical embolization, which is a technique with internal iliac artery ligation with distal injection of clot thrombingeal form via arteriotomy. Reported series of 14 cases which control bleeding in all patients. Mortality was 50% due to overall injury burden, not the procedure itself. Complications occurred in 2 cases of impotence, no rectal or bladder or buttocks ischemia. So RIPOA now is the bridge. It's not definitive control. It's usually in zone 3. Temporary stabilization of exsanguination of hemorrhage, and best in center with protocols and trained teams and hybrid room. There are clear indications such as profound shock, peri-arrest or arrest, and to buy you time for triple P or X-fix. Contraindicated if the patient has another source of hemorrhage, and contraindicated also for prolonged use, and should not be delay faster. So in reality, it's falling out of favor in many centers because time to access is critical, and it requires expertise and dedicated protocols, and the evidence of mortality benefit is mixed. Next, we'll talk about open pelvic fracture, which is a devastating injury as mortality can reach up to 50%. The sequence is usually bleeding control, contamination control, and then we go with fixation. This is the sequence of management. Packing, binder, and embolization X-fix are used, but triple P often fails since tamponade is lost due to the open wound. The colostomy debate continues. Do it for rectal or perineal wound near the anus, not for anterior wound. Despite all effort, bleeding first and then sepsis remain the biggest effects. Always don't forget the genitourinary system. Bladder, urethral injury, 6 to 10% increased risk in men, and severe fracture, 80% extraperitoneal bladder rupture. Full is 10 to 14 days. Interperitoneal rupture, you go with laparotomy and repair. Straddle fracture, which is bilateral pubic rami, suspect urethral injury. Blood at meatus, perineal hematoma, suspect urethral injury. Retrograde ureterogram before Foley's or careful senior attempt, and suprapubic catheter if Foley cannot be. And also the rectal and vagina, perineal exam for laceration, vaginal speculum in female. Suspected rectal injury, you go with examination under anesthesia and sigmoidoscopy. There is a pattern of soft tissue injury, which is the Morilla Valley lesion, which is a close internal degloving. It causes seroma, hematoma, risk of necrosis. You usually go with the incision and drainage, and then debridement of the soft tissue. So my take-home message is binder first always, as it's simple, fast, and life-saving. Triple P is the cornerstone. X-fix stabilize the frame. Angioembolization is complementary. Repoa is only for bridge. Speed matters. Time to hemorrhage control equals survival. Keep it simple in limited resources. Binder, Triple P, X-fix for all saves lives. So this is my last slide, and these are my references. Thank you very much, and it was a pleasure.
شكرا دكتور أحمد. This is good presentation. For the third
Next speaker, Dr. Abdulsalam Abdullah Hadi Mohsin, Orthopedic and Trauma Consultant, Associated Professor, Faculty of Medicine, University of Aden, Head of the Department of Specialized Surgery, College of Medicine Aden, Head of Orthopedic and Trauma Al Jamhuriya Hospital, Trainer in Doctor Without Borders Organization, MSF, Consultant of the Center of Artificial Prosthesis. He speak about our experience in management of open fracture and closed fracture.
Alaikum. Thank you for giving me this chance to speak about open fracture mainly compared with closed fractures. Open fracture compared to closed fracture, there is a wound communicate the fracture hematoma and external environment. This comparison make the open fracture at risk with 3 factors: risk of infection compared to closed fracture, soft tissue attachment is bad, and bone healing also deteriorate in open fractures. I have 3 cases to show you how to deal with open fractures. First case, 30 years old male, adult male, sustained mine injury in al-mukha, traumatic amputation, left leg open fracture, gastilo type 3A, both hands, deep lacerations, and left distal femoral condyle interarticular with exposed cartilage and patellar tendon.
الآن فيديو هذا
When we take
فيديو شوي
and photo for any
هذا المريض شو اسمه مصن
to take sent for photograph to use his pictures in the research or in presentations. This also should be activated, a consent for photograph taken. We did with balloon amputation, left leg debridement and external fixation. We first save life of patient by perform Atlas protocol. Then we save limb by examination distal to the trauma to assess the temperature of the leg, the pulsation if there is a pulse, and the capillary refilling. We did the debridement and external fixator. The second debridement, approximation of the wounds. And for the fracture, intercondylar, interarticular, we did 2 cannulated screws. Percutaneous, less invasive. It is type of internal, but we use it sometimes in like this interarticular fractures. Pelvic was normal. To cover the exposed bone, flap. Within 1 month, the patient improved his soft tissue conditions. Even the below knee stump is okay. The donor site, and patient start to walk and to apply the prosthesis. The second case is 12 years old female with multiple gunshots. First inlet in the right hip, exit in the sacrum and affected sacroiliac joint. The second inlet is suprapatellar gunshot and exit at the posteromedial left knee. Third inlet popliteal and exit muscle soft tissue injury. Right open neck femur fracture. The right neck femur fracture, we did 3 cannulated screws. Did 3 cannulated screws. We preserved the neck shaft angle, and we try to preserve to keep the head, to prevent vascular necrosis of the head, and we did a derotational bar to protect our weak fixation of the neck of femur. The third case, this is the follow-up, the second case, follow-up X-ray, good healing of the neck of femur. Sorry, neck of femur process, healing process is good. With simple fixation, can we achieve a good results? Third case, 11 years old male, post-traffic accident. The wound extended from the posterior flank to the groin area, even reached the perineum, but not deep to the perineum, but deep to the neck of femur. There is a neck of femur fracture on the side, and left neck femur right side open, and left femur close fracture. We open fractures by early debridement, early induction of antibiotic, and percutaneous fixation of the neck of femur right side. And we did pediatric flexible nails for the left femur and protection backslap. The soft tissue healing was good. and even a complete healing of the soft tissue and complete healing of the neck femur with preserved neck shaft angle and head without avascular necrosis, and left femur also healed with pediatric elastic nails. The open fracture passed through important era. Of life. This before the World War. The First and Second World War, the aim is to preserve the life of patient. The second is limb preservation. It is the time of World War First and Second. And the third era of infection prevention, this era of antibiotic discovery, 1949, and decreased the percent of infection at that time. And our aim is of restoration of the function. And thank you for the plastic surgery and for vascular surgery, help us to preserve even the limb. And we try to return the patient to his normal life. ما نسيت رشيد. We will continue. How to deal with open fracture in the emergency room. We pass through phases. The first phase is emergency phase. The emergency phase started from the site of injury, the site of accident, and part of it completed in the emergency room. To study the staff who deal with the ambulance. The early induction of antibiotic is the very important factor to prevent infection. The antibiotic given within 3 hours, the antibiotic given within 3 hours, it will decrease dramatically infection. And the second factor is early debridement. This emergency phase to apply the Atlas protocol, ABCD, but I have to concentrate on C, because sometimes we deal with and we forget the pulsatile bleeding or bleeding at the bleeding from the extremity. For that, you have to do a teamwork, one to compress on the fracture and bleeding site, pulsatile bleeding, and the other deal with the airway and breathing. I think all of us will know it, but need to perform it properly. The second phase, we call it of OT, patient theater phase. The proper antibiotic and to apply the antibiotic and to apply the external fixator, usually for open fracture. We use internal fixation and open fractures. The third phase of open fracture treatment is the physiotherapy and rehabilitation phase. It started from the first day of treatment to the trauma. Always we deal with the distal part of the trauma. Examination of the neurovascular condition distal to the trauma. Physiotherapy distal to the trauma. We continue both phase, which is rehabilitation and physiotherapy. This is the form of consent form for medical photography taken. And you have should we have an idea splintage in the operation and the emergency part. Even in the to know about the practice and splinting and tools which use to immobilize the fracture because it would decrease the complications. The classification of open fracture, as we know it is Gastello classification, but I will not go deep with this classification. Before to go for type 1, 2, type 3, type 2, type 3, there is two big types, which is internal open fracture and external open fracture. Internal open fracture mean the fracture, the cause of opening is from within, from due to a sharp bone from inside. This mostly clean wound. The second type is external open fracture, which is the cause of this open fracture is from outside, and mostly this wound is contaminated. 3 types and 3 subtypes. Every type can be very simple, fracture wound and open fracture and clean from within. It can be very serious, can be associated with brachial artery, for example, and cause vascular injury and can lead to gangrene. For that, every type of this Castello 1, 2, 3 and subtypes, 3 subtypes can be simple and easy treatable and can be severe and purely salvageable. For example, this type 3 can be simple and can be complicated. This is type 2B, can be simple and can be salvageable. And type C can be only puncture wound with vascular injury which needs repair, and can be crushed with soft tissue loss and salvageable limb. Case presented to the ER late more than 6 hours, consider it as infected or contaminated wound. The early induction, the antibiotic, the antitetanus, and the analgesia factor, as I mentioned, also the debridement. We have to know the timing of induction of antibiotic, the timing of debridement, the timing of closure of the wound, and also the type of stabilization of open fracture. According to a more of studies show, if you delay the induction of antibiotic more than 3 hours, you will increase the infection rate to 35%. And even with another 3 hours, it will increase more than 35%. Type 1, type 2, type 3, subtype 1, subtype 2, subtype 3, and 1 antibiotic, cephalosporin, 2 antibiotics, aminoglycoside in addition to cephalosporin, and 3 antibiotics. But in addition to the type of open fracture, we have to take consideration about the environment of open fracture. The environment like arm injury, contamination, we have to add a third antibiotics like aminoglycoside to prevent a Clostridium infection, which lead to gangrene. Also, when the trauma is in the freshwater environment, we have to add fluoroquinolones or 4th generation cephalosporins. In the soil water injuries, يعني إصابة البحار, we have to add doxycycline, saline we use for irrigation of open fracture. Saline with swab, saline with antibiotic. Most of studies said the washing with saline with Castol swab, it is better than pure and antibiotic mixed saline because decrease dramatically the infection rate. The low pressure
Time.
the the high pressure, despite the high pressure, irrigation is expensive. The amount of saline is 3 liters for every type of distillate. So, for type 6 liters for type 3 to 9 liters for type 3. To how to deal with the skin properly, you have to preserve the skin as you can, and aggressive development of fascia, also assessment of the muscles by forces, and tendons, nerves need experience to deal with them. The big pieces detach it from the soft tissue, if you can, to keep it and wash it, and the environment of the fracture is good, better to keep it. But this wounds, the first type, gastrula type 1, puncture wound, leave it. The clean wounds, even bigger, you can do full. You have to leave observation and perform delay primary closure. The infected wounds, better to leave it for healing by secondary intention. Conclusion, remember number 3, and 3 subtypes. And treatment, infection, soft tissue coverage, delay, fracture healing, 3 types of antibiotic, 3 antibiotic, anti-tetanus, analgesia, 3 surgeons, plastic and vascular surgeon, 3 hours for injection of antibiotic, 3 hours more, it will to 30% and more than 50% risk of infection, 3 liters of saline for every type. Thank you.
نشكر الدكتور عبد السلام، ونعتذر بالنيابة عن أطباء البلاستيك والفاسكولار اللي صفقوا التصفيق الأول ولخبطوا الآن مع الأسئلة.
شكرا للي قدموا كلهم. Thank you for all presentations, and we can give for short time 1 question for every one of the speakers. أي حد عنده سؤال؟ تفضل دكتور خالد.
صراحة يعني الموضوع اللي تطرق له الدكتور محمد بابليك والدكتور عبد السلام موضوع ممتاز جدا، اللي هو ايش؟ الأوبن فراكشر of the lower limb and how to self-fake the limb and when you decide amputation. فصراحة الجستلو كلاسيفيكيشن مهم جدا بالنسبة لجميع طلاب البورد من أي تخصص، جراحة عامة، أورثوبيديك، بلاستيك، لازم يراجعوا الجستلو كلاسيفيكيشن. والجستلو كلاسيفيكيشن يتبعوا حاجة اسمها منجل كلاسيفيكيشن أو منجل ديسيشن، يعني when you decide amputation. When you decide amputation it is very difficult option، صعب على المريض وصعب على الدكتور انه ايش يقول امبوتيشن. فقرار الامبوتيشن محتاج ديسيشن من 4 اخصائيين، اللي هو الاورثوبيديك سيرجن والبلاستيك سيرجن والفاسكولار سيرجن والجنرال سيرجن. كل الناس تكتب الدوكومنت على الملف حق المريض ان هذا نن سلفجبل نن ريكونستكتبل لم، بعدين يتخذ قرار الامبوتيشن. فصراحة يعني أنا رسالتي أحب أوجهها إنه لا أحد يتخذ قرار الامبوتيشن لوحده، لازم ال4 تخصصات هذه تكتب في ملف المريض إنها non salvageable non reconstructable limb before you decide amputation. هذا بس يعني.
شكرا دكتور خالد. حد عنده؟ صراحة ملاحظة مهمة للدكتور خالد، ومشان ما يتحمل المسؤولية شخص واحد. تفضل دكتوراه.
بسم الله الرحمن الرحيم. دكتور عوض يسر، اورثوبيديك سيرجن. السؤال الاول دكتور عبد السلام، بالنسبه للكومبارتمنت ليم، وات از دامج كنترول؟ يعني في مثل هذه الحاله هل ننتظر حتى يحصل اللايف اوف بيشنت، او في حاجه نعملها؟ يعني هل نعمل حاجه اللي بالزرف للليم او نخليها عشان دامج كنترول؟ هذا بالنسبه. السؤال الثاني بالنسبه للوور انجري او الاوبن فراكشر. طبعا نحن اول شيء نركز على كما قال دكتور عبد السلام الفور ايرا، اللايف والليمب والانفكشن. كيف بالنسبه للريسك اوف التيتانوس؟ هل هناك في انسيدنس بعض حالات حصل لها تيتانوس؟ and what is the prevention؟ لان نحن نلاحظ في الامرجنسي في تساهل من بعض الاطباء خاصه التيتانوس بريفنشن، قاعد يعطي لك انتي بايوتيك، يعطي انالجيسك، لكن في هناك تساهل. هل هو يعطي التيتانوس توكسين او انه يعطي التيتانوس اميونوجلوبولين؟ في هناك تساهل او في هناك كما تقول لخبطه في مثل نعطي هذا او ذاك. الثالث، السؤال الثاني، ايش الانسيدنس اوف تيتانوس اند هاو تو بريفنشن؟ بالنسبه للدكتور محمد، بالنسبه للتروماتيك فينجرز، how to deal with the tendons الفلكسور اكستنسور اذا كان في traumatic amputation؟ do you lift them or you have to repair them؟
Thank you for your question. First of all, when you are dealing with a tendon injury, you should have to examine. Traumatic amputation. You see when I show the picture on the X-ray, there is a remnant of the moving phalanx. When fashioning out this remnant and then suture the extensor and flexor tendons together to make sure that you can have a functioning proximal phalanx. If you don't do this, you cannot make sure that the limb or the finger is working properly. Next of all, first of all, you should have to know the anatomy of the tendons well, because the superficial is have a bifurcation and the deep is going in between. So when you look in your hind of your mind, that the anatomy is always essential and essential. So preventing the adhesive mechanism, you should have to keep healing and the finger is moving. Don't make the finger in a spring and then make him healing. So try to do physiotherapy, you can find nothing. So keeping the movement of the sure that you are repairing well and then keep on movement so that you are retaining a good function of the tendons. Okay. For the next question for tetanus, have you ever seen a case of tetanus?
My practice, I have seen one case. It is just open fracture at the forearm. At the end, they give him tetanus toxin, and then I came to the case. I do repair for that tendon. After 2 days or 1 day, the patient came again to the ER, and he's starting to present with signs and symptoms of tetanus. Then the other branches, medicine, they will admission him to the ICU.
Unfortunately, tetanus is a very risky and rarely patient come out from an infection of this illness. So when you are dealing with, first of all, this is depend on the status of the patient. If you ask him if he have a vaccine before or not. So if he have a vaccine already, you should have to give a toxin, toxoid. And if not, you should have to give, first of all, before you are doing anything, you should have to make sure this point. Thank you very much.
دكتور عبد السلام.
واختصر إن شاء الله. I think you have to know the protocol of anti-tetanus therapy. Yes, depend on more factors. Last dose taken if pediatric, environment of fracture, type of open fracture, and you have to differentiate between immunoglobulin and toxin. There is a big protocol, you have to know it. Regarding the compartment syndrome, you ask. Yes. Yes, there is also, despite the compartment is increased pressure within the closed compartment bone fascia space, but can seen compartment syndrome in open fractures. When the there is a crash limb with open fracture, there is a communication between fracture site and external environment, but the fascia not completely ruptured and can develop also compartment. Also there is a protocols and principles to deal with compartment syndrome. If the patient presented with compartment syndrome, you have to remove any obstructing bandage or anything can cause compartment from outside. If the compartment from inside, you have to do a fasciotomy from the origin to the insertion site, complete fasciotomy. And when there is a complete fasciotomy and there is an open fracture, you have to avoid internal fixation mostly, and the best treatment is external fixator. But when the compartment syndrome presented late, better to avoid fasciotomy, because no benefit of fasciotomy, and you will add another risk factor to put this patient risk of infection. Better to keep it closed and to end with fibrosis than to open it and develop risk of infection. Obvious.
شكرا لكل المناقشين، شكرا للي قدموا الحالات، وهذا نقتبس من أول سيشن.
بسم الله الرحمن الرحيم. We will start our session. Our first speaker, Professor Muhammad Abdurrahman Arbab, consultant neurosurgeon, professor of neurosurgery in Khartoum University, Sudan. Dr. Muhammad Arbab graduated in 1989 in Sweden, MD and PhD. He is the founder of neurosurgical specialization in Sudan, and he is the director of Neuroscience Center in Sudan and the deputy dean of postgraduate college of in University of Khartoum. His topic about comprehensive approach in management of head injury. Case stories. تفضل.
السلام عليكم ورحمة الله. بسم الله الرحمن الرحيم. Thank you, Mr. Chairman. I should start thanking the organizing committee for the kind invitation to participate in this gathering. And I feel honored to be with you here. Well, at this time of the day, surely your brain now is deprived of main nutrients. But I hope still you are alert to grasp what I am going to say. I am just going to address the question of acute head injuries, and I chose the title Comprehensive Approach. So I hope in the next 15 minutes to go quickly over introduction, stories, medical histories, case presentation, brief notes, and concluding remarks. Let us first start with the epidemiology of the disease and why we are concerned about the head injury. The WHO recognizes head injury as a global health problem, and it is a major cause of morbidity and mortality. And an estimated about 69 million people worldwide, they suffer traumatic brain injury. And that's why the WHO is recommending preventive strategies and policies to address this issue. And they are estimating that the cost of head injury is that high, that going to trillions by the year 2030. When we say the traumatic brain injury, let us define it, and that is the accepted definition. It's just simple words: damage to the brain tissue, resulting in dysfunction of the brain due to external forces to the head. That is in very simple terms. And again, before going to the topic, remember this: that's the categorization of head injuries. We speak about minimal, mild, moderate, severe, critical, based on certain factors. When we say mild, we are referring to Glasgow scale 14, or even 14, 15, but plus brief loss of consciousness with some sort of neurologic deficit. The moderate is between 9 and 13. Now this figure 13, I put it red because the LTS now, they are recommending to move Glasgow 13 from moderate to mild. So that might be a change in the future, near future. And severe it is 5 to 8. And then the very critical is 3 to 4 in Glasgow scale. So what matters when say stories and medical history? We as doctors, we hear to our patients and they tell stories. The story might be very elaborate stories, but we need to hear. We need to listen to our patient. And out of this story, it is our job as doctors to abstract a medical history. So a story is not medical history. A story is a story. And then it is your job as a doctor to extract the medical history which is relevant to your patient. And this is very vital. So that's why we say we enjoy stories, but the patient suffers from that story. So let us start with the first case. Now, how many athletes here is the theater? I take you to the playground. That was international match. A football player, 23 years old, he just had head injury while trying to hit the ball with his head, and he fell down unconscious, and he had brief loss of consciousness. He was taken to the hospital. On arrival to the hospital, he was fully conscious. Glasgow scale was 15. There was no apparent deformity
skeletal or soft injury, and everything was fine. And in the primary survey, when we say the ABCD, usually I tell my students, please don't say ABC, rather than say the airways, the breathing, the circulation, deformity, and exposure were normal. So in the primary survey of this patient, everything was normal. And in the secondary survey, again, a CT scan was obtained, non-enhanced CT scan was obtained, and it was normal. Cervical spine was normal. All laboratory investigations were normal. So this is apparently a normal patient. A part of, in the story, he lost consciousness for a brief period. So the diagnosis was made as case of concussion. And this is categorized as mild brain injury. Okay, mild, most of brain injuries are mild. The majority of brain injuries are mild injuries. But now let us see the scenario of this mild injury. So in some 95% of this patient, the CT scan might be normal and with no intracranial pathology. And what is coming now, measures are now made to improve the indication for CT scan by using biomarkers, because people claim that CT scan has adverse effect. That's why now people now advocating looking at serum biomarkers, that the clear vibratory acidic protein, trying to check and say if it were negative, it is unlikely to find a positive finding in the CT scan. So that is to improve the indication for CT scan request. And again, in these mild patients, whom we categorize mild brain injury, 30 patients might show lesions in the MRI, though it is not recommended in the acute stage. So the football player was quite normal the next day, and he was pressing to go back. Not only this, the club, رئيس النادي, الكوتش, والجماهير. He is a very vital player, and this is championship, international championship. He wants to go back to the player. So it is your decision as a doctor to tell what to do. So diagnosis, concussion is a clinical diagnosis. It is post-traumatic reversible. And an athlete cannot return to the playground the first day of concussion. That's because the second risk of concussion is very high in the 7-10 days. So though it was mild, so your decision as doctor is not to allow this player to go back to resume playing. There were no medications for this patient. You might do a new CT scan just to see if there's any development in case he showed any further manifestations. So in this patient, in his follow-up, in the subsequent days, the player starts to claim that he feels dizzy, he's having mild headaches, he's having some sort of cognitive impairment, and they brought him to the hospital again. A follow-up CT scan was normal. And how do you tackle the problem? He's a very vital player, and I tell you, الدوري شغالة. That is post-concussion syndrome, which include headaches, dizziness, vertigo, cognitive impairment, and even neuropsychiatric symptoms. Not only this, these typically develop in the first days after brain trauma and generally resolve within few weeks to a few months. So consider it again, that is concussion, even being mild brain injury, has its consequences. And you must put that because it's a very, very common problem. Every day happens in all ages. So let's go to the case, the second case. Now we are moving to the market here now. That is fruit seller. He was brought to the hospital because there was a retained knife in his right eye the day of injury, and was referred suspecting ruptured eye globe. And the story was, he was holding a knife in his hand and was just stepping to cross a shallow canal when he fell down while holding the knife, and he rested on his knee and he fell down. So self-inflicted injury. He injured himself. It wasn't a crime, and the patient was brought to the hospital. Only few drops from the site of injury. There was no loss of consciousness whatsoever, no headache, no vomiting. In the past history, the patient is non-diabetic on oral hypoglycemics. There was no other significant disease. He is taking his medication regularly. And on presentation, he was again conscious yet anxious. Glasgow Coma scale was for 15. He is hemodynamically stable. And the local examination, there's about approximately 7 centimeter long knife coming out from the right eye with few bruises, and there were no signs of any other trauma associated, because this is a medical legal. So beware, looking at your patient, you have to expose and look for other, if there's anything that's indicative for an assault. The rest of the body was normal, and that is the patient. Fully conscious with a knife. So you can see him, and the knife stick in the right eye. I just want to again to address the young doctors. Please, when you see such a patient, there are many people around this patient enjoying looking at it. Do not enjoy equally, rather than think about how to manage your patient. The others they want to see what happened. Just ask the patient. So in his primary survey, this patient, everything was normal apart of the few bilateral crepes. Airway was present, he was fully conscious. And so it is the B and D where you want to concentrate and to manage early. And that's the secondary survey. So you see that's the effect of his diabetes. His blood sugar is high, with sugar in urine and acetone. That's why we stick to the principles when we want to investigate any patient. The CBC and the rest of the electrolytes. A CT scan was obtained, and as expected. Artifacts do not help you much to see what is happening. What you see is the track of the so that is the track, and this artifact actually. It entered here and there. So it wasn't much informative in a sense, but we have to accept it. But we went back, we ordinary skull X-ray. So you see that is that a knife was inside the cranium. So no doubt it injured the brain. So it is penetrating brain injury, non-missile penetrating injury. The patient needs hospital admission. Of course, we spoke about tetanus and the rest of it. And close monitoring, you have to treat his diabetes, and then the surgical plan. What shall we do for this patient? The knife was already broken, the wooden part of the knife broken. The knife is there. The patient is fully conscious. So you have to plan now what next. Remember your anatomy. So you should try to pull it out. You should not do that. So our decision is to go from within. We want to secure the vital tissue, which is the brain first, before that is in the theater. And that is when, so we open actually craniotomy, and we inspected first. The brain has been injured, the door has been torn. We have to save the blood vessels to prevent further complications, and then we can get out with this knife, which as you see as the images. So this part of the knife was in, and that is the part which was outside. Lucky enough, this patient, this knife did not injure the eye. As he was seeing normally with his eye. He was very lucky. Nothing happened to the eye. طبعا حماية الله ربنا حماه يعني. It just went very lateral. It pushed the whole orbit medially worse. Not only did it escape, not injuring the vital blood vessels we know, all that escaped. It is only the brain that had been injured in this patient. So again, association of your anatomy is very important. Think about your patient and plan rather than just go without planning. Always plan. The third case now is coming from a rural area where no history, just was found unconscious in a remote area. And I tell you, this remote area actually in an area very rich in hashab trees. الصمغ الحشاو عارفينه الصمغ العربي. This is shepherd actually was found unconscious. Nobody know about anything about it. Rather than they found an axe stick in his head. Nobody knows what happened to this patient who was all alone. He arrived to the hospital 3 days later, being in a remote area. Good enough, they intubated. What they have just to use ambubac to transfer this patient to the hospital. And on arrival, you see that his Glasgow scale is 6. 6 is out of 10. The scale, when you are assessing Glasgow scale in a intubated patient, which is T, so the scale is between 2 and 10. So he's scoring 6 out of 10. There were coarse crepitations bilaterally, and there is no movement on his right side. Otherwise, the hemodynamic is stable. That's the patient. Just look how it looks. All this is not with blood, and that is the wooden part of the axe, and the rest of the axe is hidden somewhere inside the brain. But was he still alive, in spite of his, for 3 days, but he's still alive. So again, people, the audience are so many. Many people looking around, and they're asking, what happened, what happened? The role of the doctor is, I want to manage this patient as quick as possible. So the ABCs again here, the 5 are involved. The airway already being intubated, the breathing was assisted by ambubac, the circulation, he was having low hemoglobin, this deformity, their deficit. So there are many to address in the same time. And this is the time you think as a doctor to go parallelly, rather one by one. In an area where there is hospital facilities, you are having people around you, let all people contribute in the management of your patient. Don't take the job all alone. And that was his profile. The secondary survey, that was his CT scan. So again, you see that is air collection, the artifact again. So it is not helping you much. But now again, see the plain X-ray, how it gives you a very basic information about the tool being used. أنا قبل قلت لكم فرار. You see these arms, side arms of the axe. And this is very vital in further management. The entry from outside inside, but good enough, nobody dared to pull it out. Because pulling it out would pull whatever hanging here, which has escaped the first injury. Doing that, you are going to cause the second injury in this patient. So these are very important to evaluate and the surgical concerns. What shall I do? So I have to open the skull. I have to open it. That's the patient side, the theater. Unfortunately, it is the left side, the dominant hemisphere, with all this dirt.
2 minutes.
Okay. So you see now, intraoperatively, that is the axe here. And when it came out, in actual fact, this patient was seen 3 months later, alive, with just residual, he can walk, with residual hemiparesis. So the last patient here is vehicle traffic accident. Initially lost consciousness with Glasgow scale 6 out of 15. She was intubated to be transferred to the hospital. And on arrival, she was intubated. Again, no other skeletal deformities. Being solely head injury, decision was made to wean the patient off sedation to assess, to make a baseline assessment in terms of Glasgow scale. And again here, the A, the B, and C, and D are well affected. So the plan is to address all these issues in the same time. And that was her CT scan. Everybody can recognize that this is the so-called diffuse axonal injury. It is diffuse axonal injury, and the admitted to the hospital, we need to couple her to a ventilator, hyperventilation, mannitol therapy, anti-seizure treatment, antibiotics, and red. And management is here things to remember to prevent fever, hypotension, hypoglycemia, optimizing of the cerebral perfusion pressure, adequate oxygenation, and remember this, the equation that is what CPP mean, and the relation of blood gases with the intracranial pressure, and that is the thing that is to address in diffuse axonal injury. That is, it is characterized pathologically by involvement of the areas vulnerable to movement, mainly the corpus callosum, the upper brain stem. And usually the lesions are hemorrhagic, and new trends give final words here. New trends on diffuse axonal injury, that is, it is advanced and non-invasive imaging, biomarkers again being used, intensive supportive cares, and innovative therapy like CAP-lane inhibitors and mitochondrial modulators, and people are moving ahead. The investigation of choice is the diffusion tensor imaging, and the biomarkers now accepted, being accepted. That is, you can say this is diffuse axonal injury. So remember, in diffuse axonal injury, early mobilization, innovative therapy, targeting the pathway of the skeleton of the fibers, stem cell therapy is coming, and gene therapy is coming. I think at this stage I cannot stop. Thank you, Mr. Chairman.
Thank you, Prof. Muhammad Arbab, for this nice presentation.
We introduce the second speaker, Dr. Ahmed Al-Rahmani from Kingdom Saudi Arabia, consultant trauma and acute care surgery, trauma lead in GI cluster, Jeddah, Kingdom Saudi Arabia, Head of Surgical Department in East Jeddah General Hospital. The topic is management of severe head injuries. You can start, Dr. Ahmed Rahmani.
السلام عليكم ورحمة الله. دكتور أحمد، دكتور أحمد هل أنت معي؟
السلام عليكم.
الصوت شوية بعيد لو ممكن.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. تفضل دكتور أحمد، لكن عندنا 15 دقيقة، الله يخليك.
إن شاء الله. Yeah, sure.
الله حياكم الله.
Okay. Thank you, scientific committee, to invite me to present in this conference. Actually, I will talk about the management of traumatic brain injury, guidelines, and general management. As mentioned by my colleague, Prof. Muhammad, about this traumatic brain injury, it's actually a leading cause of death and disability worldwide. Usually, it's affecting commonly young adults, but can affect the old after fall down, and millions of the patients who suffer from traumatic brain injury may actually facing a long term of cognitive and functional impairment. So, what are the types of injuries in traumatic brain injury? It's usually primary or secondary. Primary, which is irreversible. So, our aim in management of traumatic brain injury is to manage the secondary injury, which is influenced usually by ischemia, excitotoxicity, and inflammation. So, this is our target. How to assess? Starting by assessment of traumatic brain injury. Assessment actually started by, as any trauma patient, we are starting assessment by following the ATLS protocols, A, B, C, D, E. And the second thing, which is the cornerstone in assessment of the patient with traumatic brain injury, is GCS assessment. And also, there is a papillary examination, and neurological assessment is also remaining a key bedside tools for assessment of traumatic brain injury. Then we will go to image, which is CT scan, which is a gold standard for assessment of traumatic brain injury. It's rapid, widely available, and excellent to detect the actually any sort of injuries like hemorrhage, mass effect, and fractures, and also MRI, but it's complementary usually because it's cost and availability everywhere. Now, recently, the advanced imaging such as CT perfusion and diffusion tensor MRI starting to be used in advanced centers. Now, the actually the now talking about the blood-based biomarker that is used nowadays as a marker to reduce the use of unnecessary CT scanning and actually allow earlier identification of significant brain injury. Actually, the blood-based biomarker, which is glial fibrillary acidic protein and ubiquitin carboxyl terminal hydroxylase L1, approved nowadays by FDA in the US for triaging patients, especially in those patients who suffer from mild traumatic brain injury, to decrease the use of CT scan. And what we think, this biomarker can decrease the actually exposure of the to radiation, especially in the pediatric patients. There is many papers actually published regarding the use of these biomarkers, and all these papers actually it's showed their diagnostic rule for the traumatic brain injury. But most of these paper, it fails to actually mention any rule in prognostic rule for the traumatic brain injury. So now we will transfer to the management of the traumatic brain injury. We have a principle for management of the traumatic brain injury. Our goal in management of those patients is to avoiding hypotension, hypoxia, controlling intracranial pressure with an updated threshold with an updated threshold of greater than 22 millimeter mercury, actually considered a significant and lethal for the patient, and maintaining cerebral perfusion pressure between 60 and 70 millimeter mercury. So how we manage those patients and how we try to controlling the intracranial pressure by stepwise approach in management. So we are starting from tier 0, which is actually simple maneuver can be started in the ER even for the patient with traumatic brain injury. And then we upgrading the management until we reach the more advanced management like phenobarbital coma and also moderate hypothermia, which is now many of the actually centers, they are talking about the hypothermia and is restricted in only in some indications. The surgical management is another cornerstone, and it has many indications like hematomas with mass effect, especially if there is midline shift which is more than 1 centimeter or more, and the breast skull fracture and refractory intracranial hypertension. Here is an excellent publication which is published in 2025, last March. They are talking about depressive craniectomy for traumatic brain injury. They review actually the most common trial that is published regarding the indication of craniectomy and the outcome of that. They review the most common 3 triad, which is DICRA triad, rescue ICP triad, and rescue acute subdural hemorrhage triad. About the DICRA triad, actually, they are studying the patient who underwent medical treatment compared to the patient who is underwent the compressive craniectomy, who is failure of medical treatment on that is underwent only tier 1 medical treatment. So the outcome of this trial is the patient who underwent the compressive craniectomy, they found they have less time exposure to to high intracranial pressure with decreased ICU stay. And when they assist those patients after 6 months and 12 months, they found that the patient who underwent the compressive craniectomy had actually worse and unfavorable outcome. And after 12 months follow-up, they found there is no difference in mortality rate on those between the 2 groups. So they conclude that the early decompressive craniectomy did not improve the functional outcome or decrease mortality in long term. Now, the second triad is rescue ICP triad, who actually the assist the patient who underwent the compressive craniectomy versus the patient who underwent the medical treatment after tier 1 and 2. So the outcome of this trial is the patient who underwent the compressive craniectomy after 6 months, they found they have less mortality than those patients who underwent the medical treatment, but they found that they have more extended Glasgow outcome score at 6 months and 24 months follow-up. So they conclude that this the delayed decompressive craniectomy does not improve also the outcome in long period. The last trial, it's rescue acute subdural hemorrhage triad, which is they actually compare the patient that underwent decompressive craniectomy versus the patient underwent craniotomy only. So the outcome is no mortality difference, but after 12 months follow-up, they found there is slightly better outcome in craniotomy group. So here they conclude that the craniotomy is a good option rather than craniectomy for acute subdural hemorrhage. After this review, actually, and by this after review of these three trials, the Brain Trauma Foundation, they updated their recommendation regarding the decompressive craniotomy in a patient with traumatic brain injury. They add three new recommendation, which is categorized as level 2A recommendations. The new recommendation is the secondary decompressive craniotomy in the setting of late refractory ICP elevation is recommended to improve the mortality and favorable outcome based on the result of rescue ICP triad. And the second recommendation that is added is secondary decompressive craniotomy for early refractory intracranial pressure elevation is not recommended to improve mortality and favorable outcome. And the third recommendation that is added is secondary decompressive craniotomy, either early or late, likely reduce intracranial pressure and length of ICU stay. However, the impact of this on functional outcome is unclear. Where are they maintain their recommendation, the previous one, large fronto-temporoparietal decompressive craniotomy is recommended to decrease mortality and improve neurological outcome in a patient with severe traumatic brain injury. So they are also put take-home points as the same recommendation, and they put it in the take-home points. Now, the other measures that is need to take care in a patient with traumatic brain injury is a seizure prophylaxis. Nowadays, the update recommendation is only short-term, typically 7 days seizure prophylaxis given unless it's recommended to continue on anti-seizure medication. Hypothermia, nowadays is the prophylaxis is not always supported by evidence, and many papers came that is against the hypothermia in management of traumatic brain injuries. We will not talk about all papers here because it will take a long time, but there is many evidence against the hypothermia. And the most important thing nowadays is, which is emphasized in the modern guidelines, is early nutrition and DVT prophylaxis. So what's in the future? They started now to investigate the stem cell and neuroregenerative therapies, also multimodal monitoring like brain tissue oxygen and microdialysis is now increasingly available in advanced center. Artificial intelligence and machine learning are being tested to improve and the outcome and to improve the management and to put in the guidelines of the traumatic brain injuries. The most important point also in the management of traumatic brain injury is the management is not in the ICU. It's actually multidisciplinary team always. So rehabilitation should be started in management of those patients early to put a plan parallel to the surgical and medical management. And for mild TPI or concussion, now the updated return to play or return to the work guidelines started to be emphasized as gradual stepwise as mentioned, like the case that is Prof. Muhammad presented earlier, those patients should be not started premature to avoid the premature, to avoid the recurrence of concussion. So take-home message, traumatic brain injury is not a one-team show. It's starting from assessment, then for medical management, then for surgical team, and for other therapies, and also rehabilitation should be also involved in management of traumatic brain injury. This is my reference, and thank you again for the scientific committee and for all people for their effort.
Thank you, Dr. Ahmed Rahmani. We proceed with the next speaker.
Next speaker is Dr. Hisham Al Abdullah. He is a trauma and acute care surgery consultant at King Fahd Hospital in Al Ihsa Health Cluster. He completed the Saudi Board of General Surgery and a fellowship in trauma and care and acute care surgery at King Saud University. He currently serves as trauma coordinators in Al Ihsa Cluster. His subject is head and face injury, when to scan and when to transfer. Dr. Hisham. سجل. عبد الله مقبل
السلام عليكم جميعا ورحمة الله وبركاته. مساكم الله بالخير جميعا. My name is Hisham Al Abdullah. Today I will talk inshallah about the maxillofacial injury. This is our objectives: when to image, when to fix the fractures, so I can mandible, maxilla, zygomatico-maxillary complex, orbit, frontal bone, nasal bone, and later we'll talk about the red flags. We'll emphasize على the red flags. So if you have trauma patients, when to image the maxillofacial bone? It's simply if you have any signs or symptoms of these, I will mention facial asymmetry, deformity, step-offs, or bony crepitus. There is malocclusion, dental mobility, trismus. If you have periorbital swelling, diplopia, restricted eye movement, ophthalmos proptosis, infraorbital or supraorbital numbness. Also, if you have severe epistaxis or persistence, CS fleek with rhinorrhea, otorrhea, nasal bridge depression, or septal hematoma suspicion. There is visual changes or decrease of the vision if you have mid-face mobility. Also, if you have severe pain or inability to open mouth fully, open facial wound with bone exposure, unexplained ocular motility restriction or oculocardiac reflex, or if you have any high-risk mechanism with swelling or deformity. So you have the trauma patient, you find one of these signs or symptoms. Now, which imaging modality would you choose? Usually in the maxillofacial, the CT maxillofacial is the gold standard for bony injury. It is thin cut, the thickness from 0.5 millimeter to 1 millimeter, and without contrast. Usually we are doing the CT maxillofacial without contrast. The 3D reconstruction will help the surgery planning. So we will choose the CT, not the X-ray, not the MRI or ultrasound. So when to fix these fractures? So we'll go one by one, starting with the mandible. So what's the indication to fix the mandible? If there is malocclusion, displacement, comminution, open fracture, edentulous, or atrophic segments. Usually we'll do it early repair, less than 72 hours, except for open contaminated fracture, or if there is airway compromise or controlled pain or uncontrolled pain or instability. Usually we'll do it earlier. Regarding the maxilla, the indication if there is mobile or displaced segments causing malocclusion or skeletal instability. Usually the operation will do after the swelling is settled down, typically within 1 to 2 weeks. Remember, we have Lefort type of fracture, Lefort 1, 2, and 3. Please consider CT angio neck to rule out the blunt cerebrovascular injury in Lefort type 2 and Lefort type 3 because it is near to the carotid canal and basal skull. Zygomatic-maxillary complex and zygomatic arch, the indication, usually if there is malar flattening with cosmetic deformity, impingement on coronoid causing trismus, infraorbital rim, nerve dysfunction, globe displacement, in ophthalmos, or significant displacement or instability. The timing usually from 1 to 2 weeks. So regarding the orbital floor, indications of the surgery, we have two emergency in the orbital floor, which is entrapment with oculocardiac reflex, also called white-eyed blue-out fracture, usually happen in the children. So we should release this entrapment of the ocular muscle within 24 to 72 hours. The other emergency is the opening lobe or orbital compartment syndrome. In the opening lobe, we stabilize the globe, then we will call the ophthalmologist to do the exploration and the repair. In the orbital compartment syndrome, we should perform the canthotomy first to release the pressure, then the orbital repair until the patient is stabilized. If there is progressive orbital diplopia in ophthalmos more than 2 millimeter or large defect more than 50% orbital floor, hypoglobus or globe malposition, usually will do the repair earlier than 2 weeks. Regarding the nasal bone and septum, the indication if there is septal hematoma, this is usually an emergency. We should act immediately because to avoid the septal necrosis. So we'll do drainage. Regarding the nasal bone fracture, if we detect it before 3 hours, we do closed reduction. After the 3 hours, we will wait till day 7 and day 10 to plan the fixation. The naso-orbital ethmoid, if it is non-displaced, will not fix it, but if it is displaced, usually we'll do the fixation to restore the medial canthus and nasal root. So earlier primary repair, less than 2 weeks, is associated with better outcomes. If we delay it more than 2 weeks, it will increase the risk of nasolacrimal obstruction and scarring. Regarding the frontal sinus, we have the posterior table and anterior table. Posterior table, as you see here, it is near to the cranial cavity. So if there is posterior table displacement, comminution, and CS fleek or intracranial injury, this is an emergency and we should repair it or fix it within 12 to 48 hours. The anterior table, if it is stable, will not do anything. If it is displaced more than 2 to 5 millimeter, or there is outflow tract injury, usually we'll do the repair within 1 to 2 weeks once swelling is subside. In this slide, I put the red flag list, put it together so you can memorize it easily. When to fix the fracture now, or you act immediately. If there is a threatened airway or uncontrolled hemorrhage, if there is orbital compartment syndrome or retrobulbar hematoma, usually we'll do lateral catheectomy immediately. In the pediatric group, there is blue out with entrapment and ocular cardiac reflex. If there is open globe, we should protect the globe. Then, as we said, to consult the ophthalmology. If there is frontal sinus posterior table fracture, we'll see a cephalic. So this type of fracture usually requires cranialization. So summary, if you have a trauma patient as another trauma patient or any trauma patient, you will start with ABC. You will check the neuro and eye check. You will, if there is any suspicion of maxillofacial fracture, as we said, you will request for CT maxillofacial. Will involve CT angio neck if we have Lefort type 2 and type 3. Urgent OR if any of the red flags list above. Then we plan the definitive fixation. Most displaced zygomatic-maxillary complex, Lefort, naso-orbital, ethmoid, orbital floor repairs within 1 to 2 weeks. Regarding the nasal fracture, as we said, if you detected it before 3 hours, you will do closed reduction. Otherwise, you will wait until day 7 and 10 to fix it. And if there is septal hematoma, we'll act immediately to drain this hematoma to avoid the necrosis. This is my references, and thank you for listening. I'm happy to answer your question if you have.
Thank you, Dr. Hisham. Now we open the discussions. If there is any question or comments. تفضلي يا دكتورة. دكتور علي، عند دكتور علي ميكروفون.
السلام عليكم. Again, دكتورة سماح معدن. First of all, I would like to thank أو بالعربي أتكلم. أشكر كل القائمين على هذا المؤتمر، وأشكر كل الأساتذة الأخصائيين اللي تحدثوا وأثرونا بالمعلومات، وكل المستمعين الكرام. فقط هي كانت رسالة من وحي ملاحظتي لتو سلايدز اليوم. واحدة كانت في السوليد أورجانز مع الدكتور نواف، والأخيرة كانت مع البروفيسور محمد أباد بالهذه السيجن. هي النايف أو أي penetrating non-measles means knife, stick of wood, stick of iron inside the body. This is the message for my younger colleagues, I mean, all the professors know it. But when you see in the ER, when you see patients came with such injury, that means there is an object penetrate inside the body, anywhere in the body, head, face, chest, abdomen, thigh. Please, please, please don't remove in the ER. This object needs to be removed inside operation theater when the patient is anesthetized and drugged for surgery. The surgeon inside, with all precautions that the anesthetist taken, because such object can, it is injured and penetrate. It may injure a major vessel, and when you remove it in the ER, this object may be seal the site of the bleeding. When you remove in the ER, maybe disastrous bleeding happen and you lose your patient within 5 minutes or less. So this object needs to be removed in OT under anesthesia by the surgeon and by all precautions of fluids, blood, and prepared for this patient. Just this the message, and thank you.
Thank you, Dr. Asama. Any questions or comments? Okay, thank you. We finish our 4th sessions, and now we are going to prayer and lunch.
كده كده مين عادل
يعني مشكورين استجبتوا بس مش عندنا
لا لا شكرا شكرا لكم جميعا يوتيوب وفي شكرا جميعا الحاضرين في زوم واليوتيوب على حضورهم معنا وخصوصا المتحدثين. شكرا جزيلا على تواجدكم معنا، وإن شاء الله نلتقي في مؤتمرات قادمة يا رب.
خلاص finish.